Welcome, everyone, to the Transformation Nurse Academy podcast. This is our weekly episode, Talk with Kevin, where we cover topics for all nursing fields with extra emphasis on emergency and critical nursing. Get ready for candid discussions that explore the vast landscape of nursing and beyond.
Welcome, everybody, to the Transformation Nurse Academy podcast. My name is Kevin, and thank you guys for coming back. I told you last week when we talked about time management that I was going to do a better job at posting better content on our Transformation Nurse Academy podcast. Anyway, we're going to work head to toe, but before you can work head to toe, if you work in the ER, if you don't work in the ER, it doesn't matter. We're going to learn about the ESI tool, or the Emergency Severity Index. It is a triage system that we use in the emergency department to determine whether a patient needs to be seen right away. I used all the tools that I could, and I created a tool on the website. So all you have to do is go in there, answer questions, and then hit enter, and it will fucking give you the ESI number. But we're going to talk about this. So welcome again. I appreciate you. We're going to provide you with some valuable information on how to navigate the emergency healthcare system. Again, my name is Kevin, and today we're going to be talking about the Emergency Severity Index score, the ESI triage tool. So let's get started. A little brief overview. The emergency department, we see patients all the time. Here in California, we do have ratios, but the hospitals don't always fucking follow them. Sometimes the doctors don't follow them, but, we have to follow them as nurses because our scope of practice says we must advocate for our patients, and we don't want to be taking care of 20,000 damn patients that are sick as shit, because otherwise we're going to make trouble for ourselves and for the patients. So the ED is designed to handle a wide range of emergencies, from minor injuries to life-threatening conditions. The process typically involves several steps: registration, triage, waiting, medical evaluation, treatment, and either discharge or admission. So first, when you come into the ED, you'll register at the front with the registration clerk. I'm not sure about another state, so a lot of you guys shout out and tell me about this. But here in California, we do not ask for your insurance or payment information until after you have received a medical screening evaluation, because it's against the law, at least here in California. I thought it was against the law nationwide, but I could be wrong as shit. So first, you'll start by registering. After you register, then one of the key components to the ED process is the triage system. So in most hospitals, the Emergency Severity Index score, or the ESI, is used to prioritize patients on the basis of severity of their conditions and the resources they need. So the ESI system categorizes patients into 5 levels. ESI 1 indicates a patient whose needs are immediate, life-saving, emergent, someone that's in cardiac arrest, they're going to die soon. That's ESI 1. ESI 2 includes patients who are at high risk or in severe pain, such as in those with chest pain or severe asthma attacks. ESI 3 patients need multiple resources, and we'll talk about that, like blood tests and imaging, but are still considered stable. ESI 4 patients need one resource, like an X-ray, and in the ESI patients, they don't need any immediate resources, and those are typically patients who come to the ED who's had a skin tag for like 15 years that wants it fucking removed, or maybe they just forgot to get their pain medicine refilled and they want some prescriptions refilled. So that would be an ESI 5. So how does the ESI score affect you? Well, understanding your ESI score can help set expectations for patients and their ED visits. The higher the ESI levels, like ESI 1, ESI 2, they are seen immediately because those patients require urgent care. If you don't see them, patients are going to die. And we'll talk about some of those patients. If you or your family member has an ESI 4 or ESI 5, you might experience longer waits. In other words, you probably shouldn't fucking come to the ED. But we can't deny anybody coming to the ED. But if you're ESI 4 or ESI 5, maybe you should go to the fucking urgent care or your primary care doctor, because you will wait quite a while and you're going to get mad at us. But the ED, I forgot what the ED stands for. Oh, yeah, emergency department. So filling refills of prescriptions, it's not an emergency. That's more fucking like you should have fucking set that shit up on auto refill. But who am I to judge? Anyway, it's important to stay calm. If you're a patient or if you're a nurse, stay calm and make sure you understand the ESI score that we've been given. Well, you're not supposed to change your ESI score, but I guess it could change. but you want to remain calm. You want to stay patient during the wait. Our healthcare teams are working hard to ensure that everyone receives the care that they need as quickly as possible. It's not that we're fucking trying to cheat you or trying to shove you in the corner. However, if you come in by ambulance with chest pain, we're going to do an EKG. And if the EKG is normal, we're going to send your ass to the waiting room because it's not life threatening. If you do come in for a refill and you see somebody else coming in, and then we see them and they've been here shorter time to you, it could be because the ESI levels are higher on that patient than you and they require immediate treatment. So don't be upset that people get pushed ahead of you. That's just the way it is. We're not in Disneyland where we have to wait our turn in line. So now let's go through the simple checklist to understand what to expect during the ED visit. So again, one, we're going to register at the registration desk. Two, the nurse will assess your condition and assign your ESI score. That's what you do as a nurse. Using the ESI tool, you'll assign the ESI score. Takes about 5 to 15 minutes. Then you're going to be waiting in the waiting room, depending on your ESI score. And you may need to wait a little bit longer than some others. The higher the ESI scores, you will be seen sooner. The lower your ESI scores, the longer you're going to wait or your patient's going to wait. If you don't understand this as a nurse, how are you going to explain it to your patients? But you should. Then you're going to have a medical evaluation, which sometimes what ERs are doing now at the same time with triage, and we're also doing what's called a medical screening evaluation, because not only do we have a nurse, a registered nurse there, we have a NP or a PA. Sometimes physicians will sit out in the triage waiting room area and we'll do our medical evaluation screening, MSC, at the same time as we're doing our triage. Not always, but we try to do that because it tries to save time for the patient. When we do the medical screening evaluation by the NP, the PA, or the MD, they may order some labs, they may order some x-rays, maybe some medications. So we'll bring you into the back. A lot of hospitals have called it our internal waiting room. Where I work, we call it the blue zone. We bring you back in, we do your labs, we do your IVs, we may give you some PO medicines, we may send you for x-ray and ultrasound, but then we leave you in what we call an internal waiting room. So we don't want to send you back out to the lobby. And people get mad, but look, we're doing what we need to do. We understand that you're sick, but we got to wait for the results because we can't just magically throw some shit at your ass if we don't know what the fuck's wrong with you. So remember that, nurses. Find the underlying cause before you start treating people and shit. After the medical screening evaluation, like I said, we do the treatments, we do the test. This can take anywhere from 30 minutes to 60 minutes. Sometimes it can take longer depending on how long the backup is. Like if you're going for a CAT scan or your patient's going for a CAT scan and they need to have a contrast CAT scan, a lot of facilities make us draw a lab and look for the creatinine and BUN to check for kidney function before we start shoving the dye in. That's going to take even longer because it can take the lab 15 minutes, 20 minutes to run the test. What are you going to do? After we do all the treatments and the tests, then we'll decide whether we're going to discharge or we're going to take you upstairs to admission. So again, that could take extra time. So just think about these things when you're doing your ESI triage level. So I'm going to go through, I created what's called an ESI triage book. It's a little ebook that you nurses can download and stuff. It's free. You don't have to do anything. I would like you to subscribe and let us know about what you're going through and what kind of systems you have in your hospital. I'm not trying to sell you anything. I'm just trying to learn how I can better help you as a nurse. I'm a mentor, so if you want to send me a few bucks and shit, because the stuff I do, I'm always up for that stuff. You know, we're on Facebook, we're on TikTok, we're on Instagram. So you can always throw us it's the tip happy shit nowadays. So, all right, let me find my shit here. So, anyway, I got a triage book. It's pretty damn long. It's like, I don't know, 25 damn pages. So, the key components to the ESI triage, there's a 5-level system. Like we said, we went through 1 through 5. The importance of the ESI in emergency care. ESI helps streamline the triage process, allowing nurses to quickly and accurately assess the patient's need and prioritize care. This patient is critical in busy emergency departments. Resource management, by predicting the resources required for each patient. The ESI helps in managing the allocation of medical personnel, equipment, and time. This ensures that the high acuity patients receive the necessary resources without delay. Because remember, if you're coming in for refill of a prescription, we don't want to waste resources on you. I mean, I know that sounds terrible of us, but we got to find a way to use our resources more efficiently. The ESI triage is standardized. The ESI provides a consistent framework for triage, reducing variability in patient assessment and ensuring a uniform approach to emergency care. Here's the problem though: when people triage, they use emotions and shit. And so that's one thing that nurses have to learn not to do is use emotions when you're trying to triage because that can come back to bite you in the ass. So that's why I created the ESI triage tool, and I'll share my screen to show you with it later. Training and education, ESI serves as an excellent training tool for new emergency department staff or old. It provides a clear guideline and criteria, helping nurses develop critical thinking and decision skills when making these essential triage decisions. It's based upon data and research. The structured nature of the ESI allows for a collection of valuable data on patient acuity and resources. This data can be used for research, quality improvement initiatives, and optimizing emergency department operations. The problem is when you let fucking doctors start increasing or decreasing the ESI level, that's when you gotta say, listen, motherfucker, stay in your lane. Let the nurses learn to triage because we have evidence based upon this, not feelings and shit. All right, so let's talk about the different levels. ESI 1, immediate life saving intervention. The criteria patients requiring immediate life saving interventions. Conditions include severe respiratory distress, major trauma, cardiac arrest, and severe hemorrhage. So here's an example: a patient is in cardiac arrest needing CPR and defibrillation. A patient with severe trauma and unstable vital signs requiring emergency surgery, or a patient with obstructive airway requiring immediate intubation. That would be an ESI 1. ESI 2, high risk of deterioration or severe pain and distress. And I know a lot of you nurses are fucking jaded in the ED. Everybody complains out of a 10 out of a 10. However, I'm going to give you some examples. Critical criteria: patients at high risk of rapid deterioration who present with severe pain or distress. Conditions include chest pain suggestive of myocardial infarction. In other words, chest pain with some nausea, vomiting, diarrhea, gastric complaints for women, lower back pain for women, pale, diaphoretic, and the vital signs go along with it. So, an example would be a patient with chest pain and EKG changes, a patient with shortness of breath and low oxygen saturation. And when I mean low, I mean fucking like in the 60s and 70s, not motherfucking low 90s or high 80s, or COPD patients. A patient with acute confusion and a history of diabetes, possibly experiencing diabetic ketoacidosis. So I know this sounds crazy, but if you have a patient who is intoxicated and they have a laceration or scrape on their face and they say they can't remember if they fell, that is an ESI 2. And you should put them in C-spine until you've cleared them. ESI 3 is multiple resources needed. Criteria: patients who require multiple resources such as lab tests, imaging, IV fluids, but are not in immediate danger. Stable patients with complex medical conditions. So an example would be a patient with abdominal pain needing blood tests, someone needing an ultrasound like an OP patient, IV fluids, a patient with a deep laceration requiring sutures, even a tetanus shot and antibiotics are considered ESI 3. Or a patient with moderate asthma exacerbation requiring nebulizing treatment and monitoring. That would be considered an ESI 3 patient. ESI 4, only one resource needed. Patients who require only one resource, such as a single diagnostic test. So if somebody came in with a broken ankle or a possible broken ankle, I'm not a doctor, and we only needed to do an x-ray, that could be an ESI 4, but does a patient need a casting? So a patient with simple fracture needing x-ray and casting, a patient with a sore throat needing a rapid strep test, a patient with a minor laceration needing simple wound closure. Steri strips, those would be an ESI 4. ESI 5, no resources needed. Patients who do not require any resources beyond medical examination. Conditions include minor complaints that can be resolved with self-care advice or a prescription without the need for diagnostic tests or procedures. In other words, motherfuckers who come in, they forgot on Friday night to go to the primary care doctor and say, hey, motherfucker, I need to refill my pain medication. And they forgot and they come into the ED wanting the pain refill. And that is an ESI 5. And those patients will wait quite a long time, except now if we can get the NP or the PA just to write a script if they're able to. But a lot of times they can't now in California. I don't know if it's nationwide, but here in California, they make it very hard. If I'm not mistaken, up in Washington, an NP or PA, he got his license suspended or revoked because he was not using pain contracts. So It may be a nationwide thing coming on. So please, if you're doing NP shit or PA shit and you're doing pain management for patients, make sure you have a pain contract. Cover yourself because you can get in trouble. You can lose your license and possibly even go to jail. All right, so vital signs consideration for ESI 4 and ESI 5 for patients classified as ESI 4, ESI 5. It is essential to ensure that vital signs are within normal limits for their age group. Any abnormalities in vital signs could necessitate reclassification to a higher ESI level. So, vital signs, thresholds, heart rate, respiratory rate, oxygen saturation, all that. So, let me see if I can share my screen here. I'm going to share my screen. Share my screen, Kevin. Let's begin. I'm going to go share my screen to the ESI triage. So, here's my ESI triage tool. So what you're going to do is the patient experiencing any life-threatening conditions, i.e. severe trauma, cardiac arrest, let's say no. Is a patient at risk of deterioration or in severe pain or distress? Again, let's say no. Then what's going to happen is it's going to ask you, are you going to use any resource? Well, we may draw some labs, we may do an x-ray, and that's it. And you hit next. So then you put your vital signs in. I'll make some vital signs up. We did 80 for the heart rate. We did 20 for the respirations, oxygen saturations, 96%, and we'll do blood pressure 120 over 80. Now, because I picked two resources, what do you think this triage level is going to be? Remember, one resource is ESI 4. No resources is ESI 5. Even though our vital signs are normal, we're going to hit next. I did this because I want to give you a summary. I created a thing where it will give you a chart to kind of look at the vital signs. And then once you do that, you're going to hit determine ESI level. And then look at that. It gave you ESI 3. And the reason why it's a 3 is because it needs more than one resource. So here I did a little walk-in through end users down here, life-threatening conditions, high risk, resources, heart rate, vital signs. I even put in some stuff right there. And then I put in where you could reset, you help section right here, kind of help you. Feedback if you want to provide me feedback. And then you can reset the tool again. So let's go back. Watch this. Is the patient experiencing life conditions, severe trauma, cardiac arrest? As soon as you say yes, boom, it's an ESI 1. You don't even have to guess about that. It takes the guessing off of that. All right. ESI 2, we're going to go back. We'll say no. But if you say, is the patient at risk for deterioration or is in severe pain distress? As soon as you say yes, boom, ESI 2. So those are pretty easy. Stop putting your own thought process in it. Use this tool and it will help guide you. And you can download it on your phone. You can use it on your phone. It's free. I ain't charging you for shit. You can give me feedback. I'll try to make it better for you. So it's real easy. It follows along the guidelines that the Emergency Nurses Associations have said. It's following the guidelines for the ESI triage level for the ESI index tool. All right. So watch this again. No resources. Let's just do one. We'll do an imaging and we'll do next. Again, we'll make them normal and it'll make this a patient of 4. Sats will make 98. We'll do 110 over 70. Blood pressure's nice. Again, we did this. So see right here, because everything was normal, I did all the vital signs. It didn't give you the graft. It gives you a graft only if the vital signs are normal. So watch this. I'm going to go back and I'm going to put 10. So determine ESI level. Look, ESI 4. Watch, I'll go back and watch. I'll do it again. So no, X-ray, next. We're going to do 80. Oh, we did 70. So let's put 8 for respirations. We'll do 98, and then we'll do 110 over 70. So watch this. Because I made the respirations low and I hit next, it's going to do this and it'll determine the index level. Oh, it still did a 4. So I guess if only we're doing multiple resources, does it work? I'll have to figure that out, and I'll think about that. Anyway, this is a good tool that you can use for yourself. That way you're better at your triage, right? When you're using the book and stuff that I created, don't be afraid to look at the vital signs because I gave you a lot of examples, all right? All right, so key assessment questions and vital sign measurements are helpful to determine the ESI level. So you want to think about the chief complaint. What is the primary reason for seeking emergency care in the ER? What is their history? Do they have history of diabetes? Do they have history of cardiac issues? You want to ask those questions. How severe are the symptoms on a scale of 1 to 10? And I know this is hard, but here's what I do. I try to, for women, it's a little easier. I ask, have you ever had a baby? Is it C-section or vaginal? And I try to compare that pain level to what they did with that event. For a dude, it's a little bit harder if they haven't broken any bones or anything, but you try to find a way to make someone give you a better pain scale. Because if you don't, everybody's going to say they're fucking 10. Are there any associated symptoms? Are they nauseous, the vomiting, dizzying, the short of breath? Again, what's their medical history? Do they take medications? Are they taking any, or do they have any allergies to any medications? Do they have any allergies in general? Did they have any recent events that brought them here? What are their vital signs? So the normal heart rate, 60 to 100, respiratory is 12 to 20, blood pressure, you want at least 90 over 60 to 120 over 80. But again, I'm not a big numbers person when it comes to blood pressure because everybody's blood pressure is different. O2 sats, you want a greater than 90 according to the American Heart, but some hospitals have it greater than 92. Some still have it greater than 95. You just got to think about what your facility wants. Everybody's different, so you got to use your facility's policy. Temperature, you want 97 to 99 or 36.1 to 37.2 Celsius. Fever can be an indication of infection or inflammation, so fever is important too. Level of consciousness, you want to use the Glasgow Coma Scale, eye opening, following commands, things like that. Might want to use the AVPU scale, AVPU. Is the patient alert? Are they verbal? Do they only respond to pain or are they fucking unresponsive? And then you want to use the decision-making tool and stuff. Make sure you use it quickly, efficiently. So does the patient require immediate life-saving treatment? So I'm not want to go through this and hash again, but if you go through all this, my book that I created for it is very helpful. All right. So I give you scenarios in the book as well. So I'll give you an example scenario. You try to guess this. Patient is involved in a high-speed motor vehicle accident with multiple severe injuries, unstable vital signs. So what is your action? What do you want to do? And what is their ESI level? Well, because they were involved in a motor vehicle accident and they have multiple severe injuries and their vital signs are unstable, you want to make sure you immediately stabilize the bleeding if there's any bleeding, stabilize the airway, prepare for surgery if you need to. But because they were involved in a high-speed vehicle accident with multiple injuries and unstable vitals, they're automatically ESI 1. Here's another scenario. Severe respiratory distress, cyanosis, unable to speak. Severe respiratory distress, cyanosis, unable to speak. Again, ESI 1. They need to be intubated most likely and have mechanical ventilation. All right. How about this one? Diabetic patient. Patient found confused, blood sugars reading above 500. Ketones are present in the urine. Course of action, you want to give IV fluids, insulin therapy, close monitoring. Again, automatically ESI 2. So I give you these resources in the book. I got to go back through this book. I see that I got a lot of pages that I screwed up. I'm going to have to redo this, James. So remember, just make sure I redo it before you post the episode. I'm going through this book now. I'm seeing kind of crazy, how crazy I didn't tidy it up and shit. All right. Anyway, I give you a lot of resources in this book that you can go through. It will help you. So make sure that you understand the ESI levels. You want to make sure that the Emergency Severity Index score, remember that's based upon a 5-level triage system. It helps you prioritize the patient's severity of the condition. Remember, this one that we're working on this week is the adult version. Next week, we'll work on the pediatric version. It's pretty close to the same, but, the criteria are a little different. So we'll go through that. And again, I'll create an ESI triage tool for pediatric patients. I'll create an ESI triage tool manual as well for the pediatric patients. But you want to make sure that you look at the key components. Initial patient assessment, use your decision-making algorithm. Again, look and review the common scenarios I give you. Communication skills. If you're not sure, talk to a coworker, talk to a physician. Use real-life case studies, that way you can practice. Think about the pitfalls, be aware of the common mistakes that people make and look at the strategies to avoid those common pitfalls. Does that make sense? So you want to make sure that you look at the pitfalls. So if you type in my ebook, Pitfalls of ESI Triage, it will take you there. And this is what it will tell you. All right, so here we are. When you look at the pitfalls, all right, let's see, pitfalls. I got to get there. Pitfalls. Hold on a second. I got to get to my book here. Sorry about that. I wasn't prepared. I'm a terrible fucking host. All right, so when we get to pitfalls, I'm not very good at searching it. That may be why, James. I got to look at the thing here. So here's pitfall. So pitfall number 1, we under triage, where a patient condition is more severe than initially assessed. This can happen if symptoms are minimized or not fully disclosed. That's a good thing because sometimes patients give 3 fucking stories in the ED. They'll get a triage nurse one story, then they'll bring the patient back to me. The patient will give me a story, so that's story number 2, and then the fucking physician shows up and they give another story. Listen, patients, give the fucking truth the first time around so we don't delay treatment. Pitfall number 2 is over-triage, where patients are assigned a higher level of ESI than necessary. This can lead to resource strain and longer wait times for other patients. So one of the strategies, use objective criteria and vital signs to guide you. So if you use my tool, you won't have this problem. Communication breakdowns, another pitfall, where misunderstandings between staff or with patients lead to incorrect triage decisions. Strategy, maintain clear and consistent communication. Use closed loop communication to confirm understanding. So those are some pitfalls that you would like to think about. All right. All right, you guys. So I know that's kind of a short episode, but it's all right. I want you to use the triage tool that I created. I want you to use the triage book I created. It's free. You download it. The triage tool is free. Work on the ESI triage for adults this week. And then next week, we're going to move on to the ESI triage tool for pediatrics. And then following that, each week, we're going to start from head to toe. We're going to do neuro. Then we're going to do cardiovascular. Then we're going to do respiratory, GIGU, and then we'll throw in some other shit to help you out. All right? Because we're going to transform you to be an awesome fucking nurse. And if you have any questions, you're not sure about anything, let me know. All right? So I truly appreciate you guys. I hope that you learned a lot this time. Email me, text me, message me on Facebook, Instagram, TikTok. We appreciate you again, all right? This is Kevin with the Transformation Nurse Academy podcast. I hope you had a great time. Fuck you bitches and stay safe.
Don't miss out. Engage with us weekly. Share your thoughts and let's transform the nursing landscape together.